And now we go to Dr. Muna Bend with routine clinical use of OCTA for retina diseases. Yes.
Good morning, and thank you to AO, APAO, and AIOS for this opportunity. Let me just start with a case that most of us are familiar with. The diabetic who goes from place to place with an OCT of the central 3 millimeters, asking you whether there is an alternative for injections. This gentleman also had floaters in the left eye. And just an hour later, I could tell him the good news, looking at his OCTA, that he doesn't only need injections, he needs laser as well. So I will be speaking in the next few minutes that there is definitely a role for routine clinical use of OCTA in the retina clinic. These are the common retinal disorders we see in the retina clinic, and if you look at the investigations we do, OCTA forms part of the investigation for almost half of them, maybe a little more. Why OCTA? It studies the vasculature, both normal and abnormal, and also gives you a corresponding B scan. We see the deep capillary plexus and choroidal vasculature, something we don't see on a fluorescein angiogram. It's quick, non-invasive, and most commercial instruments now have standardized protocols. It's easily repeatable if you feel you missed something or you feel you need to look somewhere else. It's very practical for frequent monitoring, especially if you're looking at personalized treatment intervals, which is what all drugs are now looking at. It bypasses leakage. There's no risk of dye allergy, no challenge with IV access. If performed properly, it can replace most indications for invasive angiography. And quantitative measurements are possible, but currently more as a research tool. And this is not a fancy OCTA machine. This is a regular 12 millimeter scan on a standard SD OCT. And this patient with proliferative diabetic retinopathy, center it on the macula. You see neovascles here, you see non-perfusion here, neovascularization of the disc. Center it on the disc and you see there's non-perfusion nasally as well. Similar in the left eye, and you also have the B scans showing that there's macular edema. So quick way to make your decision and explain to the patient. It also helps to distinguish neovascularization versus IRMA. You see here the vitreoretinal interface slab picking up a small area of neovascularization, which is not seen in the superficial slab, and also in the B scan with the flow signal. Whereas in intraretinal microvascular abnormalities, where you don't need to do PRP, the vitreoretinal interface is quite clear. This is a gentleman on a regular follow-up. He has a little uncontrolled hypertension. There's better eye with non-proliferative diabetic retinopathy, sudden blur in vision in the right eye, a little bit of retinal whitening, and an OCTA shows that there is absence of flow signal temporal to the fovea in both eyes, the B scan showing hyperreflectivity of the inner retinal layers, indicating that there is some loss of retinal perfusion in that area. We do evaluate our patients with CRVO every month. This is a patient with non-ischemic CRVO, cystoid macular edema. A month later, you see even though fixation is poor, you have artifacts, you're able to see there is perfusion, there's macular edema. A good result after one ranibizumab. The second ranibizumab, again, if you look at the B scan, everything is fine, but the red flag comes here. There is ischemia indicating that this patient is now progressing to ischemic CRVO. And we all know we have to look at both eyes. This patient came for treatment in the left eye, and if you look at the asymptomatic right eye, there is a quiet little new vessel here, and this, I think, is probably one of the major indications for doing OCT angiogram in your clinic, looking at the fellow eye for a quiet neovascular membrane. You can also do it to monitor whether membranes are growing when you're only observing the patient. Here you see a patient, this was as much as he could get with treatment, there's no fluid, but with each OCT angiogram done at monthly intervals, you see this membrane is growing in size. And then we have the doctor shopper, the world traveler, and the opinion seeker. who has all kinds of investigations done. Someone's done a B scan and said, if you develop a CNV, you need treatment. Someone's done a wide-angled fluorescein and said, yeah, maybe you need injections. And then he comes for a third opinion. And then what I did, I just did a small 3x3 OCTA scan and said, yes, you do have a neovascular membrane under this elevated RP and you need an injection. Incidentally, he was also a genetic mutation for pattern dystrophy. And here is something which is an artifact, looks like a membrane, but it's actually an artifact caused by RP atrophy in the fellow eye. And some things never end. A patient who had PDR with drusen, vitreous surgery, didn't do too well. He vanished, came back one day, all was fine. A year later, everything fine except a few more hemorrhages at the posterior pole. And now we find he's developed a CNVM also, so the next chapter begins. Bilateral choroiditis, very difficult to find anything, but look at the OCTA. It picks up this small neovascular network, shrinks with treatment, also choroidal thickening, which is managed with medical management. This is choriocapillaries flow signal defects due to a granuloma, again, which improves with treatment. The limitations, the learning curve, artifacts can be misinterpreted. We still don't have wide field imaging on all systems. Definitely there is a role in OCTA for clinical diseases. And what's more, it's validated by my worthy opponent, Dr. Sadda, who says he uses it for everything except a PVD. So I rest my case.
Thank you so much, Dr.